Hello everyone, and welcome to the webinar, A Costing Tool You Can Use, demonstrating the value of services for people experiencing homelessness. My name is Molly Meinbress, and I will be the moderator for today's webinar, which is a production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration, Office of Special Population Health. This session is being recorded and will be archived in 3 business days. This is a 1.5-hour presentation with the last 15 minutes reserved for questions and answers. Below the presentation slide on your screen, there's a chat box for participant questions and technical issues. If you are experiencing an urgent technical issue, please call Krista at 615-226-2292 for immediate assistance. Please type your questions for our presenters in the chat box at any time during the webinar. A selected number of questions will be answered at the end of the presentation during the Q&A session. Thank you for participating in this webinar. Today's session will highlight a costing tool developed by researchers at the Heller School for Social Policy and Management at Brandeis University. This costing tool can be used within the healthcare for the homeless setting to conduct basic economic analyses of homeless services to measure costs and benefits. Webinar registrants should have received a copy of the costing tool via email to reference during the webinar. Please call Krista at 615-226-2292 if you did not receive the costing tool, and she can send it to you. Dawn Shepard will be the first presenter today. Dawn is a professor at the Heller School for Social Policy and Management and head of the Cost and Value Group at the Schneider Institutes for Health Policy, Brandeis University. He was one of the co-authors of one of the most widely cited papers in health economics, the paper that developed the standard measure in cost-effectiveness analysis in health, the QALY, for Quality Adjusted Life Year. He has been conducting research in cost-effectiveness for the past 4 decades. He also developed the treatment cost assessment tool for costing behavioral health programs. Our second presenter will be Cynthia Shamples. Cynthia is a researcher at the Heller School Schneider Institutes for Health Policy at Brandeis University. Her research interests include health disparities, public health delivery and finance systems, cost-effectiveness evaluation, immigrant health, and health policy, especially around HIV/AIDS, tuberculosis, and dengue. She has served on Massachusetts Medical Advisory Committee for the elimination of tuberculosis since 2004. In 2011, she was awarded the Charles DeGraw Award by the National TB Controllers Association. Prior to her graduate studies, she spent 10 years in the nonprofit sector advancing poverty reduction, including affordable housing and living wages. Our third presenter will be Sue Carson-Moore. Sue is the Director of Homeless Services at Charles Drew Health Center in Omaha, Nebraska. Sue is currently working on 2 research projects, a CMS-funded study titled Community Health Workers and Healthcare for the Homeless, a partnership to promote primary care, and an NIAAA-funded study through the University of Massachusetts titled Women's Health Survey, Substance Abuse, Mental Health, and Health Among Homeless Women in Primary Care. Sue is passionate about advocating for the homeless population. She is a board member for Metro Area Continuum for the Care for the Homeless and proud to facilitate the first community advisory board in the state of Nebraska. I will now hand the microphone to Dawn and Cynthia to begin our presentation.
Thank you very much, Molly, and my thanks to the National Healthcare for the Homeless Council. I'm thrilled to be part of this presentation. I'll be talking about a costing tool that you can use. This Excel-based tool will help us demonstrate the value of services for people experiencing homelessness. Our learning objectives today are first to learn how to use this tool to calculate the cost per unduplicated client and to interpret the findings using the costing tool. Next, we'll calculate the cost per key service output and to interpret these findings using the tool. And finally, we'll explain the key components of a cost-benefit analysis and apply these with the tool. The cost analysis tools for homeless service programs are really a suite of three interrelated tools. The development of these received original funding from the Substance Abuse and Mental Health Services Administration, or SAMHSA. They're Excel-based, so that they used software that should be very familiar to all of us, and almost all of us have on our personal computer. There are really three tools within this suite. First, the costing tool that will allow us to calculate the cost per client for a given service. Second are a cost offsets calculator that can apply for supportive housing programs. Cost offsets mean we spend money on a program, but we offset other costs that society experiences. And then the third is the cost offsets calculator for a case management program. In the same way, when money is spent on case management, it offsets cost of other healthcare, prison services, hospital services, and other kinds of social services. As an introduction to this, I wanted to begin with an analogy to a familiar tool. This is a picture of an iPhone, so thanks to the late Steve Jobs, and shows if instead of sitting here in Boston, if I wanted to be sitting right beside Molly Meinbras at the National Health Care for the Homeless office in Nashville, I could put that into my smartphone, and it would tell me the route to get there. It would take 16 hours and 27 minutes. In doing that calculation, my smartphone is combining internal information that it's gotten from me, namely where my location is, and then external information that it has in the memory and databases, which is the road network between Boston and Nashville, Tennessee, and it merges the internal and the external information together to solve the problem of figuring out the route. The costing tool will do the same thing. It takes information from our program and external information from the literature and merges those together in looking at cost offsets. As a way of explaining the costing tool, we'll begin with a hypothetical case management program. And you can open up your own tool now if you want to follow on, or do so later. When you first open up the tool, it's an Excel tool, it has a series of sheets, as Excel workbooks do. Each of the sheets are interrelated, and they have hyperlinks so that if you click on something, it will take you to another sheet. So this is the starting place, and lists the table of contents, and you can see the tabs along the bottom for each of these sheets. TOC is the abbreviation for table of contents. It might seem quite formidable to see so many sheets, but fortunately it's nowhere near that complicated. Most of the sheets, as you see, are informational, that provide background, help you understand some of the logic behind this and some of the finer points on refining it. There are only a few sheets that are absolutely necessary to do it, and those core sheets are the ones that we'll go through on this webinar. And this table of contents, which we'll come back to, serves as our roadmap to keep track of where we are and what needs to be done next. And so you can see from this that the first thing we need to do is in red on the right, that says please fill in, and takes us to the basics sheet. So if we clicked on the basics tab, it would take us to this basic sheet where we need information about our program. The first thing we need is the name of the program, and the hypothetical example is Better Life Center. The next is the type of program, and here and for several places, you'll see a little arrow to the right of the box, and that indicates that there's a pull-down menu within the Excel piece, And if you click on that, it opens up the menu of the types of programs that are built into the tool. And two of the programs, the first one, which is here, case management or supportive housing, the program has some extra capabilities for those two types. So this hypothetical program is a case management tool, and I click on that, and it highlights that in blue, as you can see, and puts in case management as the type of program. We can then go ahead and fill the other items in: the year, the fiscal year of the data that we're using, and the location. Both of these facts are used in the cost analysis to relate this program to the literature part of the external data. The next sheet that we need to go to is the sheet called line. And so if we click on that tab or follow the hyperlink, we'll initially open up with an empty sheet with space to list each of the line items in our program. And we would go to the program budget to get the information for this, to fill it in. And so we can see the first item here is salaries. We've put in the amount. If the salaries of our program, if this were a larger organization, it may be that only part of the personnel, and thus only part of the salaries, are devoted to the particular program that we're costing. And so in this example, only 19% of the personnel salaries go to the program. And so we put in this percent of line items, 19%. The computer does the calculation for us and comes up with $158,000, and so on for the payroll taxes and benefits. Because this is Excel, we can use the usual formulas. So if the payroll taxes are a percentage of the salaries, we can put in that percentage and the computer will do the calculations for us. And so we continue this process for each of the line items here. In the type of expense, we have a pull-down choice, and the types are personnel, recurrent, capital, or other. And so for each item, we've clicked on the appropriate category for that item. I'll continue now. The next piece that we need to go to is the program outputs, and I'll pass over to my colleague Cynthia, who will take over here.
Thank you so much, Don. And again, thank you to the organizers for this conference, or for this webinar. It's great. For this page then, there's two main tasks, which is to think about what unit you want to analyze. We need to identify first the number of unduplicated clients and add that in. And here in the example, you can see there's 377. And then what's the primary service measure you're going to look at? In this example, we chose encounters, particularly case management encounters. And then if you do have the full Excel sheet open, you can scroll down, and for program types, there's various examples. For an emergency shelter, you might want to look at bed nights. For a food program, you may want to identify the number of meals that were served in the given time frame, analysis time frame. If you're looking at a permanent supportive housing program, you may want to look at the housing person months, like how many months the people were stably housed, for example. And then we'll go to the next. Once you've entered that in, this slide begins to uncover some of the additional opportunities that you have to do offsets analysis for either case management or supportive housing. You'll notice that this is the Off CM tab, which stands for offsets for case management. The tab next to it, if you see below there in the yellow, is Off SH, and that's where you would go to fill in if you were analyzing a supportive housing program. This is a faraway view. The next slide has a little bit closer so you can read some of the material, but this is to give you a sense of the literature was a bit sparse on case management because these types of studies are really quite involved and expensive, but we were able to identify 4 studies, and then the final line is an average of the offsets that were identified. Now, when you add in what year on the basics page that you want to identify, that column G will update automatically, adjusting for year in inflation, and then also what region is. And that's why it's important to fill in the basics sheet first, so that these types of pieces of the tools will update automatically. If you go to the next slide, you'll see that we chose in column A, there's a blank space, and if you do another, mouse over the bottom right-hand corner, you'll see a drop-down menu that says Use. And that's the way that you would choose and indicate to the rest of the tool's functionalities that you wanted to use the offsets from this particular study. Or in this case, what we recommend people doing is to start with the average to give yourself a base case analysis, which you'll see in a subsequent sheet that we'll discuss in a little bit. But then from that base case, then you can experiment. But each of these studies, again, have some descriptions, and it would be important to think about if you wanted to experiment from your base case, would be to look at the population served and the exact nature of the intensive case management that was provided in each of these studies. And there you would pick the one that best matches your personal program's characteristics. Okay, so we've identified which offsets we wanted to use. And going to the next slide, what we'll see is just the example of some of the research that was used to populate these various offsets sheets. And then before we have the big reveal on the results sheet, it's good to just check back in with the table of contents, because now what you'll see when those fields in column E once were red, now they're green, and they indicate that you have entered data there and you're ready to go to the results because results are available. And here we find basically all of the results relating to all of the data that you have entered in some form or another. So we'll have the total cost summary, and it'll break down the cost of the program in the 4 categories that we discussed earlier. You'll get the services provided and the unit cost per service, so that's all there. And then in the right-hand column, that's where the additional, if you analyze the case management, and really the literature really relates to intensive case management, so I should probably put that caveat in there explicitly. So if you're analyzing an intensive case management program or a supportive housing program, then the right side will also show results. For example, the offsets value or the cost offset per unduplicated client is in the neighborhood of $15,000, which means that this is actually a cost-saving program when you look at the benefit-cost ratio, putting together all of that data. And I think I'm going to turn it back over to Don.
Thanks very much. And just to build on the points that Cynthia raised, the benefit-cost ratio is the relationship between the cost of the program per client and the economic benefits in terms of savings and other healthcare costs and other kinds of societal costs. And so the internal data, to use our GPS analogy, was the line items that we filled in. And those were summarized here at the bottom with a cost of $1,708 per client. And then based on the literature of studies that have looked at the offsets for intensive case management, when we pick the average, the offset per client is the $15,000 that Cynthia mentioned. And so the ratio of the $15,000 to the $1,708 is this benefit cost ratio. When that number is greater than 1, as it is here, it means the program is favorable. And when it's relatively high, as it is here with 8.95, we would say this program is extremely favorable. And for every dollar that we're investing in the program, we're returning $8.95 of economic benefits to society. from this hypothetical program. So now with this hypothetical example, we'll turn to a real example that relates to community health workers from a CMS innovation grant. And we're fortunate to have with us as a co-presenter Sue Moore from the Charles Drew Health Center, who's been involved with this project. So Sue, I wonder if you could first introduce yourself, say a few words about the program you manage and where it's located.
All right, good afternoon. My name is Sue Carson Moore, and I'm the Director of the Homeless Services at Charles Drew Health Center. Charles Drew is a FQHC that's located in Omaha, Nebraska, and the project we're working on right now is titled Community Health Workers and Healthcare for the Homeless, and it's a partnership to promote primary care. It's funded through the National Healthcare for the Homeless Council. We partner with hospitals to try to get some emergency room diversion for frequent flyers and reduce the cost to the hospital, kind of part of the goal. And we've titled our program the Community Health Assistance Program, also known as CHAP.
Thanks very much, Sue. So now, in this dialogue with Sue, we'd like now to turn to our tool. We started with a fresh copy of the costing tool. We use a new copy for each iteration or each application that we're doing. And with a fresh copy, as you can see, it starts with the basics page as the first part to be filled in. And so we'll now then go to the basics page here and asking Sue some questions about it. We have Sue first tell us the short name of your program that you'd like to use, what kind of program, the year, and what part of the country you're in.
All right, we've titled it the Community Health Assistance Program, and we selected case management rather than healthcare for the homeless because it involves a lot of intensive case management to help these people. This is from our fiscal year 2013, and Nebraska is considered Midwest urban.
Thanks very much, Sue. So the next sheet that we saw that we need to do is the sheet called line, where we indicate the line items of expenses. And let's begin with the most important item of personnel. And so let me ask you, Sue, for the personnel during the last fiscal year, can you indicate the salaries and wages that they were paid?
Yes, we had 2 community health workers, which is why you see 1 and 2. And together it was $66,007. One of the community health workers was working for the entire 12 months. The other one came on the project later, so we only charged for 5 months.
Thanks very much. And the next item we see is the overhead rate. Some organizations may not charge specifically for one, and there we'd want to get an estimate of what it costs for occupancy costs. Any cost that's not listed separately as an explicit item in the item list would be factored into the overhead. So the cost of keeping the lights and the heat on, the electricity, would be part of the overhead. And so could you give us your estimate of what that rate should be, Sue?
About 13%.
Thanks. And the next item, of course, is personnel, because we're dealing with salaries. And Sue, were these people working 100% for the CHAP program?
Yes, they are.
Thanks. And so we've put in 100%, and then the computer calculates 100% of that. And so I'll go now to the next sheet, and we want to go through this dialogue about each of the other kinds of items. So, Sue, do these people get paid fringe benefits? And if so, tell us how you calculated those.
Well, the grant allowed for 22% for fringe benefits, so we had a fixed amount we could charge.
Okay, thanks. And the computer helped us do the 22% calculation. The overhead rate, of course, will be the same for each of these items. And what were some of the other non-personnel expenses and the items involved, Sue?
The cell phone, which for both CHWs came to $1,414. travel, which included their monthly mileage as well as any bus passes that we provided to any of the patients to get them to appointments. The cost of getting the CHWs to the National Healthcare for the Homeless Council and to get the training that was required for the program. The dollar amount for the travel was $2,493. The conference was $11,197. The equipment charge of $2,614 was for their laptops and physically for the phones. Supplies came to $626, and that was just basically paper, pens, those types of items that we would require. The managerial costs were for my time, and we estimated approximately $6,000 for that.
That's great. Thank you. Thanks very much for those items. And for all of those items, were they used entirely just for this program, Sue?
That's correct.
And so in the percent column, we've put in 100% for each of the items that Sue just described. And then if we look at the type of expense for the fringe benefits, they're supporting the personnel, so we put those in. The managerial costs, as Sue said, was primarily her time, so that's also personnel. And then the other items we've put in as recurrent costs, and those will be used for the costing profile that we'll see in a few minutes. And these are all of the items that it took to run this program. So our next part is to look at the output of the program. For this program, we have two kinds of outputs. One is the number, the first one is the number of clients, which we'll be using to get the cost per unduplicated client. For a year-long program, this is a little bit tricky, and so I'll ask you two questions, Sue. First of all, how many clients were there at the start of the program, at the start of the year?
There were 35.
Okay, and then did you end up with the same number of clients, or did the number get smaller as the year went on, Sue?
The number got smaller due to the death of some of our clients, so we ended the year with 33.
Okay, and so for this purpose of getting the number of clients, we'd like the midpoint of this range from the beginning and end. And so we've taken the midpoint of the starting number that Sue said of 35 and the ending number that Sue said of 33, and the midpoint of that is 34. As our primary service measure, we've chosen the number of contacts that the community health workers have with the clients over the course of the year. How many contacts were there, Sue?
436.
Thanks very much, Sue. So we've put that in as the primary service number. So now we've put in the cost, we've put in the outputs. Let's go back to the table of contents, and it helps us with our roadmap of keeping us where we are, keeping track of where we are. So we see on the basics that it now is green and says complete. On the line, it shows the data have been entered. And on the output line, it also shows that that's complete. And so at this point, we've entered all of the key items, and we see a green at the bottom that says that results are available. So now we'll go to the results page, and the cost calculator has now calculated the cost profile and cost results for Sue's program. So we see the name of the program, Community Health Assistance Program. The overall costs, as we can see, are about $118,000. And now those costs have been broken down into two of the four categories applied in Sue's program: personnel costs that are 82%, and recurrent costs are about 17% of those. On the services, we had the average number of unduplicated clients over the year. That was 34, and the 436 contacts. And so now the cost calculator gives us a few important results. At first, it tells us the average cost per unduplicated client over the year, and that's $3,485. And then it also tells us what the cost is of one client contact, which was $178. If we look at the right-hand side of this, it now brings in some information from the literature. If we think of Sue's program, if the case management were fairly intensive, then the costing tool has brought in information from the literature and gets a cost offset per unduplicated client of about $25,000. The net cost then says we're spending $3,000, we're saving $25,000, and so overall this program is saving society money of $21,000 for each client, or in terms of a benefit cost ratio is 7.18. That's the $25,000 in offsets divided by $34.85. If the benefit cost ratio is greater than 1, it says that the program is favorable. And if it's a lot greater than 1, as this number would illustrate, it's quite a bit, it's quite favorable. Then I'm going to go back for a couple more questions on this. And let me ask questions. So now that we have some of the results from the program, can you say how you plan to use this costing tool as your project is continuing?
Well, over the course of the research project, my hopes that the tool will give us the data we need to understand the true cost of the program and to show the savings that the hospitals might achieve through the use of community health workers and intensive case management.
Thanks very much. And now the program will end in a few months. You're trying to figure out ways of continuing it. How would this tool be used after the program ends?
I think the long-term use of the cost tool will assist us in preparing a report with relevant data regarding cost savings for the hospitals. Our goal, of course, would be that the hospital would see the benefit in hiring community health workers through Charles Drew Health Center to provide the services for them. Services that they can offer include like assistance with applying for Social Security or SSDI, food stamps, Medicaid, Medicare, housing. So a lot of those right there will help the hospital reduce their costs. We also will be able to show the hospitals that by having community health workers continue their partnerships with the hospitals, they'll see a reduction in emergency and hospital visits, reduced Medicaid and Medicare reimbursements and uncompensated costs, a reduction in health disparities, and then on the society end, we'll see improved quality of care, quality of life, health outcomes, patient satisfaction, and competence and skills in self-managing healthcare settings that the individuals can be led on a lifelong path of improved health status. So it's a win-win, and we want to let the hospitals see that so that they choose to continue the program.
Thanks very much, Sue. So I'd now like to bring in some other data that we have from the historical information that you gathered for the year before your program started. For one hospital, you had 35 clients who started the program, and I understand that the hospital helped you compile the cost of their care in the year prior to the program. That was $564,000. And so we can do this simple arithmetic of calculating the hospital cost per participant, this total cost divided by the number of clients that we had historical data for, and we end up with a historical cost of $16,136. On the previous results tab, we recall that we calculated the cost per midpoint or per average participant of $34.85. And so one of the ways that we can use this tool is to calculate what would be the break-even point of cost reduction? We did this calculation by taking the cost per participant of our program, the $3,400, and dividing that by the historical cost of what each of these clients had cost in hospital care in the previous year, $16,000, and that ratio is 22%. And now what that tells us is that if this program reduced hospital cost by 22%, it would break even in terms of hospital costs alone. 22% of $16,000 is $3,485, which is exactly what the program cost. And so by providing the community health workers and reducing hospital emergency room and hospital admissions and saving at least 22% of those costs, the program would pay for itself. And so that's one of the factors, as Sue talked about, discussing it with the hospital and asking if they would be willing to continue supporting this when the external funding ends. This would be a point for them to make. A lot of these costs are bad debt, and so just offsetting a small part of that would save the relatively modest cost per client of the community health workers. I'd now like to give an illustrative cost reduction. Suppose the reduction in costs were a little bit more than 22%. Suppose they were 40%. And if you look back at the tab that Cynthia showed earlier of the intensive case management programs, we saw numbers up to 50% or so reduction in hospital costs from some of the studies in the literature. So the 40% is a very plausible number. When this study is over, we'll find the actual numbers at Omaha and the other sites. But let's use this 40% application. The savings in hospital costs would then be 40% of $16,000, which is $6,454. And so now we can do a benefit cost ratio based on hospital costs alone. And we do that by the numerator is the economic benefits, 6454. The denominator is the cost per participant of the program, and that ratio is 1.9. Again, that ratio is greater than 1, and it says just considering the hospital costs with this illustrative reduction, the benefits exceed the cost, or the program would be worthwhile for the hospital. That is, if it invested $3,485 per client in paying for case management, it would save $64.54 per client in hospital costs over a year, and it's saving more than the cost of the program. Other services that might benefit also, there may be other social services such as cash assistance that the programs might benefit, that might also benefit from this if the clients engaged in any criminal activity, that may also be reduced from the case management services and various other kinds of social services. The last bullet shows another way of interpreting the benefit cost ratio. It says that for every dollar invested in case management, the program returns $1.90 in hospital savings. So we've simply taken the 1.9 ratio and multiplied it by a hypothetical $1 investment. Again, we're returning more money than the dollar invested. It's another way of saying that the program is economically beneficial for this hypothetical 40% reduction in hospital costs. The calculation we did a few minutes ago shows that anytime the savings are at least 22% reduction in hospital costs, this cost-benefit ratio will be favorable based on hospital costs alone. The case management tool tab in the tool is looking at a broader set of savings that go beyond just hospital costs. And so in that broader sense, the savings to society as a whole are even larger than those to the hospital sector alone. I'd like now to turn to my colleague Cynthia, and let's talk about some other applications that we found through working with various sites on this tool. Cynthia.
Thank you, Don. So we have piloted this costing set of suite of tools among a pretty wide variety of groups at this point in time, and some of the fun highlights that came out of that testing was a lot of different ways to use the tool. And so for internal management purposes, for example, they used the cost analysis portion in order to add the cost of management information software that they were thinking about purchasing and looking at the implications on cost per unit of service and sliced and diced their budgetary information in multiple ways and gave them a much richer understanding of the implication of buying the software and what its capabilities might offer. And so it was testing hypothetical situations and seeing what impact that would have. There was also a case of another Midwest provider where they looked at the cost per bed night provided in two different emergency shelters. One was in one county, one was in another county, and they found that one was typically more full or fuller than the other one, and they knew that ahead of time, but what they didn't realize was the dramatic impact on cost per unit. And when they saw that discrepancy, it triggered an internal management discussion and plan for how they were going to recruit, because they would have street workers that would go out and recruit folks to spend the night in the emergency shelters. And so it triggered a renewed effort and brainstorming around how they can improve that recruitment process because of that unit cost comparison that they had. There's also, you could look at trends over time on these unit costs that you can calculate to look at efficiencies and either show constituencies or funders or perhaps policymakers what you've gained over the past few years in terms of, let's say, you've implemented an improvement in some aspect of your program. And then in the Southwest, there was looking at the unit cost of two case management programs. One had 3 case managers and the other had 2 case managers. And so on the one hand, there was more salary and fringe benefits to spend, but on the other hand, they could handle a greater patient caseload. But then there was the recruitment issue and how many patients were they actually reaching. And so by comparing the unit cost, they were actually able to do a apples to apples comparison. And I would like to add a caveat at this point that says numbers never tell the whole story. So there might be, in an analysis like this, something helpful would be the qualitative discussion and the context around that. So what was the quality of life of the 3 case managers versus the 2 case managers? And that might help tip the balance in one way or the other if you're looking at, oh, we have to reduce staff, or we could look for another grant to fund that 3rd case manager, for example. And Don, I'll pass it back to Don to talk about the Northwest provider.
Thanks very much, Cynthia. So for this last example was a site that we worked with in the Northwest that had 2 ways it delivered services to persons experiencing homeless. It had a fixed clinic that was open all the time and clients could come into. But since clients were spread all around the city, it also had a mobile van. It was the van was like a recreational vehicle that was fitted out as a clinic inside. The van was expensive to operate. The site leased the van, so it had to pay for that. the fuel, and then it was a lot of staff labor to get it equipped each day before it went out, to make sure it was full of supplies, to have the staff get on it beforehand, travel to whatever the site was, deliver the services for several hours, and then come back to the base at the end of the day. And it did that on a weekly cycle, visiting different sites around the city each day of the week. And so the question was that very substantial expense of operating this mobile clinic worthwhile? So the way this tool worked mechanically, the site started with 2 fresh copies of the tool, and it opened one and it labeled it mobile, and the other it labeled it fixed. And then for the fixed version, it went through the process that we just did of putting in all of the line items and the share of staff time that related to the fixed clinic, and then the number of encounters per client, a number of encounters over the course of a year in the fixed one. And then it looked at the results and printed that out and saved it. And then opened up the fresh sheet called mobile, went through the same process of entering in the, for the mobile clinic, all of the staff and supplies and other items, and for joint items, the share of use that they spent on the mobile clinic, and then for the output, the number of client contacts that took place on the mobile clinic. And so the result of that was then a cost per client for the fixed site and a cost per client for the mobile site. And what was surprising was that even though the mobile site was expensive, it turned out to be less expensive per client than the fixed site, because it had this planned schedule. Each time it went to a part of the city and opened up their clinic, there was a lot of pent-up demand of clients who had been saving up their problems for the week to be able to get them efficiently treated at a site near to them. And so the high volume of services for each of those places it went to during the week meant that the cost per client was actually less for the mobile program. And so that helped to convince the site that this expense was worthwhile, and it decided to continue operating this mobile clinic. And hopefully the findings can be useful to other sites as well that face similar questions. And so we've been able to allow some other time, and so I'm going to turn it back to our moderator, Molly, for the next part.
Thank you, Dawn, Cynthia, and Sue. I'll now begin the Q&A session. The first question is for Sue, and the question is the hospital cost based on billed charges or reimbursed billing?
Well, we have 2 different hospitals that we're working with, and they gave us the data 2 different ways. One of them was the actual cost that they wrote off, and that's the one that was used for this example. The other hospital gave us the total charges amount, so we'd have to use that a little differently.
Okay, thank you, Sue. Next question, I think, will be directed at Dawn and Cynthia, and I believe it's in reference to slide 25 on the results sheet. And the question is, how is the $178 cost per number of contacts calculated?
So thanks very much, Molly. So we did that by taking the overall program cost of $118,000 for 1 year and dividing that by the number of contacts within 1 year of 436. And so that ratio gave us $178 per contact.
And that populates automatically to this results sheet once you have filled in the line sheet with all of your costs, and you've also filled in your outputs on the output sheet.
So I'll turn it back to you, Molly, for the next question.
Okay, great. The next question, and I think this will also be for Dawn and Cynthia. What do I do with in-kind donations, such as all the food brought in from community partners to our shelter?
Okay, I'll start on that one. That's an excellent question, and it really comes down to what type of analysis do you want to do, and who is your audience consuming whatever results you want to share and calculate. And so in economics, we have this thing called an economic evaluation and a financial evaluation. Now, the financial analysis or the finance analysis is going to focus on just out of pocket, you know, the concrete dollars that are coming in or going out. An economic evaluation tries to be most comprehensive, which means that you would want to estimate the approximate value of that donation, whether it be a computer or office furniture or the food that the community brings in for the nightly meal. Try to estimate those costs and include them in the line sheet. And there's a final column on the line sheet where you can put notes and say this would be an in-kind donation. And then you would have, I would say for internal management purposes, it's really good to have a full sense of, okay, if we had to pay for every last thing that we utilize in providing X, Y, or Z service, this is how much it would cost. Another group that piloted the tools here in the Northeast, they found that when they did that complete analysis, they were able to go to the policymakers who funded the vast majority because they received a per capita amount from the state, and they were able to say, look at this discrepancy between the unit cost of the services we're actually providing, so the economic value of what we're providing, and the allocation, the per unit allocation that you're giving us. And so they use that to advocate an increase. So that's just one concrete example. Okay, and Molly, for the next question.
Great, thank you, Cynthia. I think this question also will go to you and Don. How do you account for uncertainty in your point estimates?
Great question. Thank you for whoever posted. So the way we can do that is by saving multiple copies of this tool. So if we wanted to do that, we might first save it and we say the name of our project and call it best estimate. And then we might think of what are the most favorable assumptions for the costing tool. And the most favorable assumptions are those that make the costs minimal and the number of clients as high as possible. So if there were uncertainty in our data about how many clients we saved, or say on the personnel, if somebody works part-time for this, they spend part of their time on this project and part on something else, but we're not positive about the allocation of time, our best estimate would be our most likely value. But we could then say the most favorable would be, say, if the lowest share of time was attributed to this project, that would reduce the costs and make the cost-benefit ratios even more favorable. And then, so we would save that, and so we would get a set of results that are then, we have two results so far, the most likely and the most favorable, and then we can repeat the process of
your line is now muted.
Favorable. So we give the most pessimistic estimate of the number.
Your line is now unmuted.
And the highest estimate about the costs involved, or to take the in-kind costs that Cynthia was talking about, we might give the highest possible economic value for those in-kind parts. And so that would give us a least favorable estimate. And then we can interpret those by saying this range of uncertainty. If the program looks good, even in the least favorable ones, then we can be quite confident about this program. Or conversely, if it were to look bad, even at the most favorable, then we would say this program is not the best use of resources, and would try to go back to the drawing boards with some other design. If it's close to the cusp, and let's say that the best estimate was favorable, but the least favorable was unfavorable, we'd want to do two things. One is to think more carefully about the data that we're uncertain about to see if we could narrow that range. And the other is to remember, as Cynthia reminded us earlier, that this is just one tool, and there may be a lot of qualitative and intangible factors about our program, and we'd want to think about those as well as to whether the program is something that we want to continue or not. Thanks, Molly. I'll turn it back to you for the next question.
Thank you, Don. The next question is on the results sheet. How is the offset value determined, or how does the tool know which offset value on the earlier tabs to use?
I'll start with that. It uses that. It starts with the basics page where we indicated what kind of program it was. So for two of the kinds of programs, supportive housing and case management, there was enough literature to be able to quantify the offsets. So for those two, the sheets that Cynthia pointed to, it summarized the literature that we found that had economic values to it. Our starting point was to take the average of all of the case management programs, if we're doing a case management, or the average of all of the supportive housing, if we're doing a supportive housing. But the tool has a ability to refine that if we'd like to by clicking on the used column, so we could pick a subset of programs that we think are most similar to the program that we're analyzing, and then the tool will take the average of the ones that we've selected as an estimate of the offsets. Of course, every program is different, so this estimate from the literature is just a proxy or general guide about what the offsets might be. I'll turn back to you, Molly, for the next question.
Okay, thank you, Don and Cynthia. And pardon me if you've already answered this, this was sort of a follow-up to a previous question. How does the costing tool account for variance in intensity of program services as actually implemented? And if you need more clarification, I can try to do so.
Do you want to expand on it a little bit, Molly?
Okay. So further clarification, cost offsets are based on the literature, but these costs are based on programs that are likely implemented with a different level of intensity than the program in question. So why combine these two in a single ratio? Is that more clear?
I'll start, and then Don can jump in. The idea was that as we were testing the tools, there, especially on the case management, on the off SH, so if you have the Excel tools in front of you, you can scroll to the off SH tab. You'll see that there's a bit more diversity and choice among the different literature options and program descriptions. For the case management, there really wasn't very much at all to work with. So we understand, as Don just said, that this is a proxy to give you a ballpark estimate and a sense of the offsets that might be creating. And because in the testing phase, most people, we matched the population of one study, but we really matched the intensity of case management from another study, and how do we reconcile this? And our admittedly flawed, but the best available choice to us was to say, let's start with an average and work out from there. And so if you really think that, as a whole, that your program matches the Thornquist et al. From 2002, then you really should go ahead and use that. And again, from the technical side, all you would do is under column A, mouse around the bottom right-hand corner to get that drop-down menu option, and then use or don't use. So I would say don't use for the average and use for the Thornquist 2000 study. So that would be an option there. Don, did you want to add anything?
Yeah, so let me add this. It relates also to the question about sensitivity analyses and uncertainty. And so one way of doing this would be to say if we start with the average as our best estimate, we could selectively pick each one of these programs in the literature by clicking on use on that one column. I've put back on the slide here the case management first page of that. And we could save then each one as a variant. So we could take our sheet and call it 1 and 2 and so on as we go through each one of these. And the tool will then calculate at the results page, the left-hand side will be the same, the costing would be the same, but the offsets will vary for each tool, each application, each one that we select. And so we get potentially a range of offsets from different studies in the literature, and that would give us some idea about the range of values. It still may not be perfect because the number of controlled studies of case management is relatively few, and it's possible that your program isn't really like any of the ones that were set. But this gives us some idea. If you're and a help in interpreting these results, if the services in your program are more intensive, you'd expect larger offsets. If they're less intensive services, that is fewer contacts with the clients, or a narrower scope of services, or staff that are don't have as much training, then the offsets are likely to be smaller. Another principle is that the greater the problem to start with, the more services the clients were using, then likely the larger would be the offsets. And so to help with that process, in this sheet, we've put in a brief description of the clients and the services and some of the offsets. And if you go to the tab called References, or REF, you'll see the bibliographic reference. And for many of them, there's a hyperlink that will take you to the full article. And so you can read those and then see how your program compares to those, and then do a subjective adjustment to say, well, my program is less intensive, so I think my cost offsets should probably be smaller than it was in this study in the literature. Thanks, Molly.
Thank you. The next question is for Sue. What type of costs were included when you received data from the hospital?
Well, the hospital gave us the cost based on the number of ED visits, the number of inpatient admissions, and then they calculated their costs based on that. They also gave us information back about the average length of stay, so we could even find out what that cost was. But primarily the cost shown on the cost tool was from the number of ED visits and the number of inpatient admissions. Thanks, Molly.
Great, thank you, Sue. Another question, I believe, for Dawn and Cynthia. Are all of the cited studies from peer-reviewed sources?
In the references, many of them are, but not all of them. Our goal was really to find as much literature as we could of controlled studies, and that literature was thin. So some of the studies, like the slide that we this slide here that I put up, a paper by Larimer, that was one of the best studies that we found. That was published in the Journal of the American Medical Association, a very highly respected medical journal, and obviously peer-reviewed. So there were a few studies like that are in peer-reviewed journals, but we've also included things that were in reports that are not necessarily peer-reviewed, but still look like they were carefully done and had useful data. So and if we go back in this sheet of the case management and the same for the supportive housing, we've put stars in, sort of like hotels get stars. So if you want the very best ones, and the star ratings are down at the bottom here explained. So 2 stars is a meta-analysis where it's combined results from several studies and is quite good, and a single star is still useful but not quite as high in caliber.
And again, if you do have the Excel sheet open in front of you, you can tab over to the Off SH tab, and you'll see that there's quite a few more studies available and of higher quality. So you'll actually see 3-star levels there with the accompanying key to what that means.
Thanks, Molly.
Okay, the next question is, the offset values vary by region based on what factors?
So what we've done is to try to take the data from the literature and then adjust that to say what would happen if that program had been replicated in the same location as your program, you as a user. So we've made 2 adjustments. One is for time. Some of the studies were published a few years ago, like the Larimer study was from the year 2009. So we've adjusted for inflation from the time that the study was done until the year that you've put in that refers to your program. And then costs also vary by region of the country. So we've gotten from the Bureau of Labor Statistics variation in costs by regions of the country, and by putting in your region, in Sue's case it was Midwest urban, we allow costs for regional adjustment. So when it does the internal data, your own program, it's your actual costs. But then for the cost offsets, it's essentially taking data from the literature and has adjusted that for cost of living differences across the country and inflation from the time of the study up through the year of your own study.
And if you're interested in looking at some of the guts of where this lives in the tools, there's a hidden sheet called OffSup, as in supplemental information about the offsets. And you will see the regional cost comparisons and the census regions and divisions of the United States and the inflation over time, the source web pages, and what the actual factors happening. And depending on if you have information filled out in the basics page and or the offsets pages, you'll see some of the behind the scenes calculation fields there as well. That's if you unhide that tab, it'll be next to the region tab, which I embarrassed to say is not up to date. So you'll only see through some of that same information, but only through year 2012, whereas the background is updated through 2014. Back to you, Molly.
Okay, great. I have a couple of follow-up questions for Sue. Was the hospital cost based on cost or reimbursement amount?
It was the cost, because as far as I know, the reimbursement amount was made up of charity care. Well, the hospitals give us back data on charity care adjustment, the self-pay if a patient paid anything on their own, what they wrote off. So this is what the actual hospital, what it costs to them.
Okay.
Did that answer the question?
I think it did. And then the next follow-up question was, were you talking about, I think it wasn't clear if you said ED or EV, but someone was asking if you were referring to emergency room visits?
Yes. Yeah, they refer to them as emergency room or emergency department. That's where it came from. ED was for emergency department.
Okay, excellent. And this next question is for all of the presenters. How would one deal with a situation if you only received charge information from the hospitals? And I'm going to see if perhaps Dawn can answer this question first.
Thanks. So let me start on that. So hospitals have charges, which charges are the amount that they'll show on a bill, and if a patient is uninsured, is typically, and they pay, is typically the amount that they're expected to pay. In most cases, those are larger than the hospital costs, and there's a mathematical adjustment that we can do based on a hospital's cost report that the hospital submits to Medicare. One can look at the internal costs that it reports in relationship to the charges and apply ratios for each department of the hospital that allows us statistically to convert from the charges to the costs. For the hospital as a whole, it's typically on the order of 80%, but it varies by department. Laboratory and pharmacy, the economic cost may be only half of the charges, whereas say an emergency room is an expensive service to operate, and the economic costs might be equal to the charges because of the hospital's need to keep that facility open and staffed 24/7. In some cases, they may report both, and then we could get the ratio for that specific hospital. See if anybody else wants to add on to that. I think I'll turn back to you then, Molly. Thanks.
Excellent. The next question is for Cynthia, and so could you please address the idea of cost per outcome?
Okay, I'm really glad somebody brought that up, because the tools actually are prepared. Let's say let me first start by saying that we address the output page, because those tend to be the things that are easiest to count, the most concrete to describe. But the tools actually do have the idea of program outcomes. And you can, it's all linked with the results page as well, but there's two additional tabs that we would want to highlight. The first tab is in the green section, although the color coding may not hold true depending on what form of Excel you're using, but it's OUTC. And if you open that up to the program outcomes, you'll notice that there's a bit of a background, and the idea is that outcomes are fuzzier things. They're not as easy to count and say concretely that my program resulted in all of this outcome. So one concrete example, for example, would be persons stably housed. So let's say this is in the basics page. I would put my title as Better Life, and then it would be a supportive housing program, and we'll be using 2013, and this would be a Northwest suburban program, for example. And then I would go to the outcome tab, and I would identify the outcome that I'm interested in applying all of my budgetary information for. So I would fill out patients stably housed for 6 months. And so there would be a little bit more of a lag. I'd have to collect information for a little bit longer. And so then I would fill in the number receiving that service in the fiscal year, the number meeting that goal, and then it would calculate the percent meeting that goal, and then we would do what's called a statistical adjustment. And that's to account for, well, some of these people may have found stable housing even without our help. And so that's, again, a fancy economic term. It's regression to the mean, and we're trying to compensate for that. And we give recommendations for where we would set that. We suggest starting off with 30%, but as Don talked about, you could do sensitivity analysis or vary that percentage to give you a range for what you think might be the most likely truth for your actual situation. And then that would give you an adjusted number meeting the goal, and then populate the cost out sheet, which is the final tab in the set. And you will see, again, if you have your Excel tools open, you'll see in that final cost out sheet that it would populate The line information is already populated totally from your line items, and then it would give you the number meeting the goal and the cost per goal achieved. And so this way you could obtain an actual cost per outcome, not just cost per output. Now, the caveat for your budget items is that you need to double check with any information that you've entered into that line out tab. Were all of these costs part of getting this outcome to be true? So anything in the program that helped the folks become stably housed for 6 months would be included in those in that line sheet, including in-kind donations, depending on if you want to do the full economic analysis or just the financial analysis. But if it was something that was just relevant to, the emergency shelter service and not the long-term housing outcome that you were seeking for some of your clients, then you wouldn't include those costs. So you may add and take away from that line sheet depending on what's most relevant, depending on that specific analysis that you're doing. Don, did you want to add?
Yeah, I would. Thanks, Cynthia. So as we have worked with sites about applying this tool, the line item and the cost for their program are generally data that sites had readily available. The data also for the outputs, the number of clients, number of services most sites had. For the part that Cynthia was just speaking about, getting the outcomes, what impact it had, the data that many sites could say was data, and Sue's program is one example, or will be as her program ends. It's possible to get before and after data. So if it's a housing program, how many clients were housed before the program, and say over the course of a year, how many clients were housed during that, or other kinds of outcome measures. The compromise, but a true economic analysis requires a piece of data that's very hard to get, and that is a counterfactual of what would have happened to these clients without this program. The studies that we found in the literature were able to do that, like this Larimer study that we put up on the slides, but generally needed some outside research funding and support to be able to find such a group and collect data from them. It's a labor-intensive process. An approximation to what might happen comes from this statistical sheet that looks for adjustment of regression to the mean. That is, using data at the start of the program and at the end of the program, we can see what's changed. Some of that change might have happened anyway, and the statistical adjustment provides an estimate of that. And then what's left over, we can say is a real benefit of the program. And so that statistical adjustment is one way of getting the approximating the impact of our program. And then these links with the literature for supportive housing and case management programs are another way of trying to say what the impact of a program is if we're not part of a real research effort to measure that explicitly. Molly, I'll turn it back to you.
Thank you so much. That was great. I have another follow-up question. It was regarding slide 25 on the results sheet regarding the cost per number of contacts, the 178 amount. So the question is basically how that cost was calculated, because, well, if you could just answer how that cost was calculated. Because 118,506 divided by 436 equals 271.80 cents. So I think this participant would like to know how 178 was calculated.
Yeah. So thanks, Molly. I think there's an update that didn't get put onto this slide. So originally, we had an earlier version of the data with a higher number of clients calculated that was 500 and something. And so when we divided by that, then we got the $178. And in the course of updating this, I updated the number of client counts and neglected to update the cost per client. So I should have done that with the latest numbers, and let me just do that now and get. And so the approximate number is about $270 per client with this updated number of clients of contacts. And great question, and one should always sort of look and see whether numbers make sense, and we're human beings and can make either make mistakes in our input, or there could be a mistake in the formulas that we haven't caught. Back to you, Molly.
Great, thank you, Don. And I just want to add here that the National Healthcare for the Homeless Council does have funding to provide on-site training and technical assistance around implementing and using this costing tool with Healthcare for the Homeless grantees. So if after this webinar you decide this is a tool you'd really like to use and get to know more intimately, please get in touch with us here at the National Healthcare for the Homeless Council, and specifically you can contact me, Molly Mindbreath, and we can try to set up a training and potentially even get Dawn and Cynthia involved in that assistance. We have about 9 minutes left and a few more questions, so I'll try to get through those. If there are any questions that don't get answered before the end of the webinar, we'll send them to the presenters, ask them to answer them, and post them on the website along with the archived webinar. So this question is for you, Dawn. The cost page appears to want info on yearly costs. Is it possible for the cost-benefit analysis to distinguish between the startup year, in which a variety of one-time costs are incurred, from subsequent steady state years? Example, initial training activities.
Great question, Molly. The answer is yes. There's a type of cost that we didn't have in the examples we looked at, but is built in, called capital costs. So commonly we think of capital costs as being some physical capital, like building or renovating a space or buying a vehicle. But it could also be the example you mentioned, like startup training. So the way we would do that is to put in that cost, go to our sheet on capital, where we would put in the number of years over which that investment would take place, if it's or would be useful. So it's easy to think about that for a vehicle. If we bought a van and we thought the van might last for 7 years, then we would put in the cost of the van, and the lifetime would be 7 years. And on this example here, we have, for this hypothetical example, we had one capital item. The depreciation is a way that accountants typically take into account the capital cost, and it takes a portion of that item per each year. An economist would do the same with training cost. If the skills that people are learning in training or the startup will be useful for several years, then using the capital sheet or depreciation, we would take the portion of that training that we would attribute to the 1 year that we're studying. And Cynthia will add.
And if you look on this slide that's showing right now, you don't see very much of it, but in, for example, row 13 and 14 and 15, you'll see that there's basically a tutorial at the top of this page that gives some background and primer. And then just at the very tiny left, bottom right-hand corner, you can see the CAP tab. That's what Don was talking about as the capital page. And so there's further tutorial at the top, and then the actual where you would enter in the information, and it'll help you make those calculations. Back to you, Molly.
Great, thank you. And the next question is for Cynthia and Dawn again. Did the statistical adjustment recommendation on the Outcomes tab come from studies of homelessness projects?
It came from a review of that literature and other kinds of literature where people were followed over time. the homeless literature is not a terribly voluminous literature. At the time we did the tool, we abstracted all of the good studies that we could find on supportive housing and case management. And as we can see, we can pretty much count them on our fingers and toes. So we brought in that, but also brought in other kinds of experience as well on trends over time to get an estimate about the statistical adjustment. Back to you, Molly.
Okay, well, we don't have any more questions, so I just want to thank the presenters again, as this will conclude our Q&A session. Thank you for joining the webinar, a costing tool you can use demonstrating the value of services for people experiencing homelessness, produced by the National Healthcare for the Homeless Council. This webinar will be archived in 3 business days, and a link to the archived webinar will be emailed once it is available. And the archive includes recording and the PowerPoint slides. Again, the National Healthcare for the Homeless Council does have funding to provide training and technical assistance. So please contact me specifically. I'm listed on our website under staff, but you can also call the phone number that's listed in the Q&A box below the slides. This meeting will now be closed. Thank you so much.